Welcome to Chapter 7. Here we will go over an overview of transcultural nursing. This starts in your text on page 95. First, we will look at some cultural concepts. Of course, you want to familiarize yourself with what exactly culture is and how it's defined. You also want to remember Madeline Leninger, who was the founder of the specialty known as transcultural nursing. She wrote that culture involved learning and transmitted knowledge about values, beliefs, rules of behavior, and lifestyle practices that guided designated groups in their thinking and actions in patterned ways. Ethnic culture has four basic characteristics that are listed in your text on page 96. They are also listed within the slide. When we look at some more cultural concepts, we want to also look at cultural diversity. And this has also been defined in several ways. Often differences in skin color, religion, and geographic area are the only elements used to identify diversity, with ethnic minorities being considered the primary sources of cultural diversity. You want to familiarize yourself with cultural humility as well, which is addressing one's cultural knowledge deficits by exploring the patient's needs from the patient's cultural perspective and exploring one's own cultural beliefs and how they might conflict with the patient's beliefs. This is a critical step toward becoming culturally competent. You want to review subcultures and, of course, minorities and what those terms actually refer to. Then we will go on to health disparities. Health disparities are higher rates of morbidity, mortality, and burden of disease in a population or community than found in the overall population. They are significant in ethnic and racial minorities. Key health indicators in the U.S. revealed a significant gap in health status between the overall American population and people of specific ethnic backgrounds. Also, when we look at minorities, I want to go back to that for a second. Of course, understand what the term actually means, and if you see this later on, you'll understand how it's broken down. So if you have, let's say, a group or a small group of Hispanics living in a predominantly Caucasian population, they, of course, being the Hispanics, would be the minority. Same for if you had a small group of Caucasians who attended a historically black or African American university, they, being the Caucasians, would be seen as the minority. So they can be seen in different terms in different aspects. So it all depends on the environment that that group or subset of people are in, if they are considered the minority or the majority. Now we will look at transcultural nursing. The term transcultural nursing is used interchangeably with cross-cultural, intercultural, and multicultural nursing, and refers to research-focused practice that focuses on patient-centered, culturally competent nursing. When we look at transcultural nursing, of course, this addresses the differences and similarities among the cultures in relation to their health, healthcare, and of course their illness. So, when caring for a diverse population, you want to ensure that you have both therapeutic communication and effective care. So you want to establish that nurse-patient interaction before you can actually provide that culturally competent care. In order to get that effective communication started, make sure that both the patient understands you as the nurse and you understand them. This is oftentimes where the communication lapses if the nurse does not understand the patient or the patient does not understand the actual nurse. So, get in tune with the different cultures, and this, of course, will take time. It won't be overnight. You will get to know what different cultures are like as far as their diet, their morals, their beliefs, their values, and it doesn't necessarily mean you have to take on any of that as the nurse. It just means that you understand them and can take care of them. As long as their values, beliefs, their morals, their religion, their diet does not ultimately affect their health care, then we oftentimes allow them to do their own thing. We could say it like that. We allow them to pretty much do their own thing as long as it doesn't hinder their care or of what we're doing as nurses for them when they come into the healthcare facility. I also want you guys to look at the other terms and definitions that provide further insight into culture and healthcare, which include acculturation, cultural blindness, cultural imposition, and cultural taboos. Those are listed in your text on page 97. And this goes back into Leninger's theory, and it also goes over those culture and healthcare definitions and terms that I just spoke about. But I also want you to look at the cultural care accommodations and reconstructing. All of these need to be encompassed in order to provide that culturally competent care to the patient and their families. And here is an illustration of Leninger's theory. It is also in your text on page 98. Here's a question that goes over health disparities and certain ethnic and racial minorities. And here is the answers and the rationale. And recall that that question was a select all that apply. Now we'll talk a little bit about culturally competent nursing care. Of course, being culturally competent means that you understand the patient. It does not necessarily mean that you have to take on everything that they believe in and what they want done. It just means that you understand them. And this will take some time. So we go over it, you won't really get the grasp of it until you experience it as a nurse. And you can really see it as a student as well, dealing with the different diverse populations, even within your class. So look at it from that perspective and take that when you go into these healthcare facilities to take care of various populations. You will see populations from all over the earth. So you have to be culturally sensitive. Of course, when you get into these healthcare facilities, you want to check on their actual policy and procedures. They do have policies on culturally competent care, You want to look at the visitation regulations, of course, translation services for those non-English speaking patients, and the dietary practices that they come in contact with. When we look at Deisher and David Hizaire, they created an assessment model to guide nurses in exploring culturally phenomena that might affect nursing care. They identify communication, space, time orientation, social organization, environmental control, and biologic variations as relevant phenomena. Their model has been used in various patient care settings to provide data that is essential to the provision of culturally competent care. And those factors that they identified are just major factors that encompass that culturally competent care. So, one of the major ones that you'll hear quite often is communication. Effective communication is key. So, we will talk about being not only culturally competent, but providing that cross cultural communication as well. You want to note that there are approximately 150 different languages that are spoken in the U.S., with Spanish, of course, being the most common. So I tell people all the time, if you're going to take a foreign language and be in healthcare, take Spanish. After Spanish, depending on the area that you're working in, I would say French, Creole would be the second, followed by maybe Portuguese, and let's see, Tagalog, which is from the Philippines. So there are a lot of languages spoken, and in my years of nursing, I've only come across maybe three or four that I have never ever heard of, but this is when an interpreter will be your best friend. Now, note that your interpreters cannot be family members, and the only reason we do that as healthcare professionals is because we do not want the family members to leave out information or tell them their interpretation of what we're saying. We want to make sure what we're actually telling the patient or communicating to the patient is actually being communicated correctly. So, in many facilities, they do have language lines. They're provided via telephone, and most oftentimes they're blue. You'll hear the nurses saying they need a blue phone, and that is usually your translation phone. And I believe the last place that I worked that had them and were using them quite frequently, the Lincoln had, I believe, over 250 languages that you could choose from, some of which I had never heard of, but apparently there were people that spoke it. So you always have assistance when it comes to communication. Also, identify those cues when you're talking to your patients. Sometimes they give you cues as to they're not understanding you. Okay, they may change the subject, they may agree with everything, and they may have a confused look. They may not have any questions. They'll laugh inappropriately when there's nothing really to laugh about. You want to look for those nonverbal cues. Most oftentimes, it'll be that confused look on their face, like, what are you talking about? So you want to look for that. And if there is a family member present that speaks English, make sure you ask them what language do they barely speak. And if they offer to translate, please tell them that although that will be okay, you want to make sure that everything you're saying is communicated correctly and you get your interpreter, which the hospital facilities do have interpreters as well, but they've utilized those blue phones more frequently than an actual interpreter. I also want you to look at the chart in your text on page 99 that goes over overcoming language barriers. I also want to note that during illness, patients of all ages tend to regress, and regression often involves language skills. So, if you're talking to, let's say, a Vietnamese woman and she may speak some English, but not a whole lot of English, and she's just kind of giving you that confused look, and she doesn't really know what's going on. Of course, you want to make sure that she understands. So, of course, if you can get your translation device, please do that. But you do want to understand that she may regress. And therefore, the English that she did speak when she was very well, she now no longer can speak that English. And so she has regressed into her Vietnamese. And if you're not fluent in Vietnamese, then your communication is then ineffective for that patient. So you want to make sure that you have effective communication. And remember that patients of all ages, not just elderly, I know we think from one spectrum to another, it's not just the elderly that regress. Any patient who is ill usually regresses in some form or fashion. When we look at culturally mediated characteristics, of course, we want to look at information disclosure. Many aspects of care may be influenced by the diverse cultural perspectives held by healthcare providers, patients, families, or significant others. Nurses should not decide that a family or patient is simply wrong, or that a patient must know of the details of his or her illness regardless of the patient's preference. So that is one thing that we have to be aware of. Similar concerns may be noted when patients refuse pain medication or treatment because of cultural beliefs regarding pain or beliefs in divine intervention or faith healing. Some people may refuse. So we have to be, again, culturally confident and culturally sensitive when it comes to these patients. Another thing is space and distance. People tend to regard the space in their immediate vicinity as an extension of themselves. The amount of space that they need between themselves and others to feel comfortable is a culturally determined phenomenon. Some people are very touchy-feely, and they're okay with you being in their personal space and putting your hand on their shoulder, whereas other people would think that is very disrespectful and you are not supposed to touch them. I know some think that Americans are very touchy-feely. I would say not all Americans are like that, because I am not touchy-feely, so I don't want you touching me, I don't want you hugging me, and things of that nature. But then again, I've been in America for over 20 years, but I'm from an island, so you never know the background of a person just assuming that they've been, in America and they have a U.S. address. They may not be from America, so their background may also influence their space and distance, their touch, and things of that nature. So if the patient does appear to position him or herself too close or too far away, the nurse should consider cultural preferences for space and distance. Ideally, the patient should be permitted to assume a position that is comfortable to him or her in terms of personal space and distance. The nurse, in turn, should be aware that the wheelchair with a disability is considered an extension of the person. Therefore, the nurse should ask the person's permission before moving or touching the wheelchair. So this is another thing that you have to be aware of when you have patients with disabilities. So if they have devices with them, this is then a part of their self. So you don't necessarily go in and take it or it because you're invading their personal space. Another characteristic is eye contact. This is also culturally determined behavior. Some people think eye contact is disrespectful, while others may think that it is a sign of respect. So you have to be culturally aware of the different ethnicities in order to provide that culturally competent care. And your text talks about Asians, Native Americans, Indo-Chinese, Arabs, Appalachians. They may consider direct eye contact impolite or aggressive, and they may avert their own eyes when talking with nurses and others whom they perceive to be in positions of authority. So it's not a sign of disrespect, whereas we in America may think it is disrespectful. In other cultures, they think that it is disrespectful or aggressive. So this is all a part of being culturally competent. Time is another characteristic. For most healthcare providers, time and promptness are extremely important. Not so much for everybody else. Let's see, for example, Hispanic people consider time in a wider frame of reference and make primary distinction between day and night. Time may also be determined according to the traditional times of meals, sleep, and other activities or events. For some people, in some cultures, the present is of the greatest importance, and time is viewed in broad ranges rather than in terms of a fixed hour. So, being flexible in regards to schedules is the best way to accommodate these differences. You want to value differences, okay? They may also influence the person's sense of priority when it comes to time. Touch is another characteristic that I touched on when we talked about space and distance. Some people aren't touchy-feely, so don't just go in and give your patient a hug. They may not want you to give them a hug, okay? Especially the male providers. Females may feel disrespected if you even, put your hand on their shoulder. So, be culturally competent when you're caring for these patients. I know we get comfortable when we're caring for patients, and you want to be friendly and things of that nature, but you have to be aware of the cultural differences that play a role. Also, observance of holidays is another characteristic. People from all cultures observe certain civil and religious holidays. Nurses should familiarize themselves with the major observances for members of the cultural groups they serve. If you're not serving different cultures and you're mainly serving, us Americans, that we celebrate, maybe let's say, just for example, Easter, Christmas, Valentine's Day, Thanksgiving, that's fine. But if you're in a place where you are serving a very diverse population, try to familiarize yourselves with the different holidays that are not just our traditional, Christmas, Thanksgiving. Familiarize yourselves with the holidays that other cultures celebrate so that, you don't burst in on, the hour of prayer that they're doing, because that can be very awkward and they would consider that very disrespectful. Another thing that you want to consider is the diet. Culture does determine which foods are served and when they are served. Of course, just for example, if you have an Islam patient or Islamic patient, of course, don't offer them ham and scalloped potatoes for dinner. that would be very disrespectful to them because they do not eat pork. So you want to look at some of the prohibited foods and beverages of the selected religious groups, and that is listed in your text on page 101 in chart 7-2. You also want to look at the religious practices such as fasting. Some religions do practice fasting, especially your or abstaining from food. Your Catholics may abstain from meat on Ash Wednesday and on Fridays during Lent. So those are the types of things that you want to be aware of when you're looking at being that culturally competent nurse. And the last characteristic that you want to pay attention to is your biologic variations. Along with the psychosocial adaptations, nurses must also consider the physiologic impact of culture patients' response to treatment, particularly medications. For example, an antihypertensive agent may work well at reducing blood pressure to acceptable levels for a Caucasian man within a 4-week time span, but it may take a much longer time to work or not work at all for an African American man with the same hypertensive problem. So those are things you want to look at as well. I know we give our patients time frames, but you want to make sure you're a little flexible. Don't say, it's gonna work in 4 weeks when you're doing your teaching. Say, it may take 4 weeks or more to work because we have to consider those different biologic variations. And you must also be aware that, ethnicity and related factors such as values and beliefs regarding the use of herbal supplements, dietary intake, and genetic factors can affect the effectiveness of treatment and adherence to treatment regimens. So you may have cultures that believe they can take herbal remedies for their hypertension, whereas you have the other spectrum who takes the prescription medication when it's supposed to be taken and they adhere to it. So those are all things that are encompassed when you're trying to be that culturally competent professional healthcare provider. Health and wellness vary among the culture as well. Interventions most commonly used in the United States has been labeled as conventional medicine. Of course, you want to look at those alternative medical systems such as your homeopathic medicines. You have the mind interventions, bio, biologically based interventions such as your Atkins diet and things of that nature, manipulative and body based methods such as massage therapy, and they have something called energy therapy that uses magnetic fields. A lot of people do participate in using these types of complementary and alternative therapies, so you must be aware of that as well. So go ahead and review those complementary and alternative therapies, also known as CAM. Those are listed in your text on page 102, and one that I want to look at in particular is the energy therapies. Now, these are defined as interventions that focus on energy fields within the body or externally using your electromagnetic fields. Some of the examples, one that they use quite often is Reiki or therapeutic touch. Also, the pulsed electromagnetic fields, magnetic fields, alternating electrical current, and direct electrical current. Those are all complementary therapies. Those have been researched and some have been seen to work, especially with patients that have chronic pain. So when you're looking at therapies that can help your patient, besides medications, because you do have those who are, they want, the natural remedies. They do not want pain medications, and they want you to recommend things that they can do when they're not in the hospital. So these are things that you can recommend to your patients. And here's a question on complementary or alternative therapy. And the answer is provided here with the rationale. When we look at causes of illness, people may view illness differently. Three major views are paradigms attempt to explain the cause of disease and illness, the biomedical or scientific view, the naturalistic or holistic perspective, and the magical religious view. So you have to see where your patient's frame of mind is and how they actually view disease. Of course, as healthcare professionals, we try to use the biomedical or scientific view. So, of course, if let's say your patient has an out of shingles, we know that this comes from the varicella zoster virus, and your patient may not know or understand what that is, what it's all about. We have to explain this to them. So, of course, nowadays everybody Googles everything. So, they may already know, where it came from. But explain it to them, ask them if they had chicken pox. If they did, tell them that, the shingles is already inside their body. I'm sure you guys have seen the commercials with the shingles outbreak and getting vaccinated and things like that. So just educate your patients, see what they know, and go from there. But of course, like I said, as healthcare providers, we tend to look for that biomedical or scientific view. Another major way in which people view the world and explain the cause of illness is the magical religious worldview. This view's basic premise that is the world is an arena in which supernatural forces dominate, and that the fate of the world and those in it depends on the action of supernatural forces for good or evil. Example of those are your voodoo, your witchcraft, faith healing. Of course, a lot of people believe that faith heals all, so they may not want medication, they may not want treatment, and this is all a part of being culturally competent. You have to understand, not necessarily believe it, but you have to understand where the patient is coming from when they tell you these things, because we will, and I will tell you now, you as nurses will hear a lot of stuff. So just be ready. And here is a chart on assessing for a patient's cultural beliefs, and that is chart 7-4, and that is also found in your text on page 104. And then lastly, you want to know yourself. Know your own cultural attitudes and beliefs as a nurse. This will help you become transcultural. This will help you become culturally competent. Recognize that everyone has cultural baggage, and this is known as ethnocentrism. So you want to review these terms as well to have an understanding. Maintain an open attitude. Like I said before, you don't have to necessarily take on your patient's cultural baggage, but you have to understand them. Avoid seeing people as alike. So don't be stereotypical. Don't group all Caucasians together. Don't group all Asians together. Don't group all the Islamic people together. Okay? They may have similar beliefs beliefs, values, but that does not necessarily mean they're all going to do the same thing. So try to understand reasons for behaviors, be a good listener, because some people just want to talk to you about, their health care and what they've been doing. You may know that it doesn't work, but they may have a cultural sense that this is what they've been doing and that's what their culture believes. So be a good listener and speak the patient's language if possible. Of course, we're not asking you as healthcare professionals to speak 150 languages, but of course, try to speak the patient's language. If not, this is where our interpreter or our blue phones come in. And of course, lastly, be yourself. We're not asking you to be anyone else but yourself. The patient will know if you're trying too hard. Trust me. So you want to be yourself, be open. Do not ever look disgusted when a patient is talking to you about their beliefs and their values and their morals, even if you do not believe it. You are their healthcare professional, so you are there to help them. And here's a question about having a language barrier and communication. And here's the answer with the rationale. And with that, that will conclude Chapter 7, which goes over the overview of transcultural nursing.